Okay, I'm going to make another presentation about mechanical ventilation for you. And so we ended up with this case study, and the reasons for intubation were the hypercarbia and the acidosis and the difficulty she had breathing. So you should have it's out of chapter 66. If you have your mechanical ventilation PowerPoint, you can follow along with me. I think I'm about slide 16. So anyway, we confirm placement with a CO2 detector, which is done right after intubation, and then we listen to lungs, and then we auscultate, and then we look for chest wall movement, and look for the SAT. If the SAT drops, it should go up because you're bagging with 100% oxygen. Then, of course, it's secured and marked at the reference points on the tube, and a chest X-ray. Then we get ABGs to make sure we're ventilating the patient okay, and continue to monitor the patient. Cuff inflation, I mentioned that about that external tubing that we inflate the internal cuff on the endotracheal tube with air. Try to keep the pressure down so you don't occlude intratracheal circulation. Then I mentioned the minimal leak techniques, stuff that respiratory therapy typically does, and they're more responsible for maintaining the appropriate cuff inflation pressure. Monitoring oxygenation status with a continuous pulse oximetry. If you have it, continuous exhaled carbon dioxide monitoring. Arterial blood gases or venous blood gases can give you good information. And then just the clinical signs of hypoxemia, like mental status changes, altered mental status, vital sign changes, color changes in mucous membranes, skin, capillary refills, and then also heart dysrhythmias. Respiratory rate, accessory muscle use, abdominal breathing, intercostal retractions. Maintaining tube patency is important. Make sure it doesn't get clogged up, and the longer the tube is in the person's trachea, the more difficult it becomes to maintain that patency. We suction as needed when the patient's coarse, when there's mucus or they're coughing, mucus in the tube. One of the biggest reasons for the alarm on the mechanical ventilator is a high pressure alarm because of the presence of obstruction with secretions. So we look for that, look at the patient struggling, and look for drops in the pulse oximetry, and hyperoxygenate prior to suctioning. And we have mainly the inline suction catheters. So we don't want to keep that tube down there long. We want to make sure we go down within 10 to 15 seconds and withdraw, not rapidly but slowly out, so you pick up the secretions as you're suctioning out. Make sure your suction isn't over negative 120 on the suction apparatus at the wall. And make sure your patients are hydrated and they have the air is possibly going through some kind of humidification system from the ventilator. They should get antibiotics a lot of times. Also, respiratory therapy may be giving inhaled bronchodilators. Oral care is very important, every 2 hours at least. Using chlorhexidine, brushing the teeth, suctioning out the mouth, head of bed up 35 to 40 degrees. Treating anxiety. In a lot of these patients, they will be on like a sedative like propofol or midazolam, which is Versed, and fentanyl for pain. But when they're coming out of that, we got to learn how to communicate with them and help them to relax and to trust us and to not be fearful. So a lot of times with intubation, there can be upper airway trauma, and we could displace the ET tube. It could go into the right main stem bronchus, and those are just repositioning complications. Some folks get a hold of the tube and pull it out. That's a problem. So they need to be reintubated or assessed for the need for reintubation. We have soft restraints that we can use to prevent the accidental displacement or dislodging of lines and tubes. Of course, if you have an unplanned extubation, stay with the patient, call for help. Provide oxygen with the bag mask, valve, or whatever else might be in the room, like a non-rebreather mask that's still hanging on the wall. And we're going to protect from aspiration, because it's a common for patients to aspirate saliva and whatnot around the cuff that's in the trachea down into the lungs. So we can do that by putting an oral gastric or nasogastric tube into the stomach, keeping that on low intermittent suction, keeping the head of bed above 45 degrees up, turning the patient, doing subglottic suctioning. Mechanical ventilation, probably should have a respiratory therapist talk to us about that. And but I will come back and do another short video in a little while. Okay?